Welcome to PRISM Rounds, the audio journal club, where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, including physicians, trainees, nurses, pharmacists, and respiratory therapists. Each episode is designed for busy clinicians who want to understand not only the headline result, but also the clinical question, study design, key findings, limitations, and bedside relevance. The goal is to make new evidence easier to digest and more useful for real-world practice. Whether you are on service preparing for rounds, teaching learners, or simply trying to stay current. I originally started making these episodes to support my own learning and review. I am sharing them publicly in case they are helpful to other clinicians and learners who are trying to keep up with the growing critical care and pulmonary literature. Everything you hear is for educational purposes only and should not be taken as medical advice. Clinical decisions should always be made in the context of the individual patient, local practice standards, and the judgment of the treating clinical team. In ICU airway management, ketamine is often treated as the default hemodynamically safer induction agent, while propofol is approached with caution because of hypotension concerns. This week's study directly tests that assumption by comparing ketamine versus propofol for rapid sequence intubation in critically ill adults. Its results remind us that induction agent choice is less about drug reputation and more about the patient's physiology, shock state, and airway process.
One of the most common assumptions in ICU airway management is that ketamine is the hemodynamically safer induction agent. But what if that advantage is smaller, shorter-lived, and less clinically decisive than we think? Today we're discussing the PROMINE trial. Propofol versus ketamine in rapid sequence intubation in critically ill patients, a prospective randomized controlled trial. The article was published on March 23, 2026 in Intensive Care Medicine. The first author is Raisa Christina Schmidt.
Right.
And, you were standing at the head of the bed, your patient's blood pressure is crashing, their oxygen is dropping, and you have to secure their airway right now.
Yeah, immediately.
You reach for a syringe, and for decades, bedside dogma has basically told you that syringe should absolutely be filled with ketamine. Well, today, we are taking a sledgehammer to that safety blanket. I'm your host, and with me is our lead analyst for today's deep dive.
Hey there.
We are both pulmonary and critical care physicians, which means we essentially live in that tight space between that crashing blood pressure and the decision of which exact drug to push.
We really do. I mean, it is the most high-stakes moment in our daily practice.
Oh, absolutely.
And the core objective of our discussion today is to zero in on a highly specific and honestly, a highly consequential clinical question asked by the PROMINE trial. We really need to find out, is ketamine actually superior to propofol for maintaining hemodynamic stability during rapid sequence intubation in critically ill ICU patients?
Right. And just so we are all on the same page, we will refer to rapid sequence intubation as RSI going forward.
Exactly. Good call.
I want to linger on that scenario at the bedside for a moment because, well, this isn't just an academic exercise for you listening. This is the absolute reality of our jobs.
It's Tuesday at 2 p.m.,
Right. When you are standing there looking at a patient whose vital signs are already precarious, the choice of induction agent feels incredibly weighty.
Because it is. It's a moment of immense vulnerability for the patient.
Yeah, the decisions we make in those 10 seconds, they reverberate through their entire ICU course.
Yeah.
We need to look closely at the traditional bedside dogma that has driven our choices for years because the stakes could not be higher.
They really couldn't. I mean, RSI in the intensive care unit is an entirely different physiological universe compared to, say, intubating a healthy, fasting patient in an elective operating room environment.
No, night and day difference.
Completely. In the OR, induction agents are given, the patient smoothly drifts off to sleep, and the airway is secured in this highly controlled setting with, robust physiological reserve.
Yeah, plenty of buffer.
Right. But in the ICU, the context is pure physiological chaos.
Chaos is the perfect word for it.
These patients are often profoundly hypoxic or severely acidotic, completely volume depleted, or actively in just profound shock.
The physiological buffer is totally gone. The literature tells us something super sobering here. Up to 45% of emergency intubations in the ICU involve life-threatening adverse events.
45%, that's huge.
Right. We are talking about severe hypotension, severe hypoxemia, or even, overt cardiac arrest occurring right there during the procedure. Almost half the time we perform this intervention to essentially save a life, we are simultaneously pushing the patient to the absolute brink of physiological collapse.
Which is exactly what brings us to the conventional wisdom surrounding our two main tools here, right? Propofol and ketamine.
Yes, the classic debate.
And this wisdom has heavily dictated practice patterns globally. So let's break down the traditional reasoning, and we can start with Propofol's reputation.
Okay, let's hear it.
So Propofol is a remarkably effective hypnotic, but it is often actively avoided, or at least, heavily scrutinized, when dealing with unstable ICU patients.
And we avoid it for very sound physiological reasons, right?
Right.
I mean, this is what is hammered into us during training.
Exactly. Day one of fellowship.
All right. Propofol causes significant vasodilation. It drops the systemic vascular resistance.
Yes. And furthermore, it is a direct myocardial depressant. If I have a patient whose blood pressure is already marginally supported, pushing a drug that simultaneously relaxes their blood vessels and tells their heart to pump with less force feels counterintuitive. Honestly, it just feels outright dangerous.
It does, and that physiological profile has led to just widespread hesitancy. Now, contrast that with ketamine's reputation.
And golden child.
Right. Ketamine is frequently selected almost reflexively in these high-stakes scenarios. The overriding belief is that ketamine provides unparalleled hemodynamic stability.
Unparalleled.
Yes, it is presumed to preserve or, in many cases, actively boost blood pressure and heart rate. It has become the automatic go-to agent when you are terrified the patient is going to crash.
But I'm starting to seriously question this reflexive behavior.
Oh!
Yeah, I mean, are we relying on ketamine like a safety blanket? Are we choosing it primarily based on this deeply ingrained physiological theory rather than solid comparative patient outcome data?
That's a real question. It feels like we hold on to ketamine because it makes us, the clinicians, feel safer at the exact moment we push the plunger. But recently, observational studies and even randomized trials comparing ketamine to etomidate have started cracking ketamine's pristine reputation.
The facade is definitely slipping.
Yeah.
And that growing skepticism is precisely what makes the PROMINE trial so vital.
Totally.
Remarkably, before this article was published, there was no prior randomized clinical trial that directly compared propofol and ketamine head-to-head specifically for RSI in the ICU setting.
Wait, none. That seems crazy given how often we use these drugs.
None. We had observational data. We had, extrapolations from the emergency department or the operating room trauma bays, but we lacked rigorous, direct, randomized evidence for our sickest medical patients.
Wow.
So the PROMINE trial was specifically designed to put this long-standing bedside assumption to a rigorous test.
Okay, so how did they actually manage to test this in such a chaotic environment? Walk me through the setting and the specific population, because conducting research during emergencies sounds like a logistical nightmare.
Oh, it is a massive challenge. So PROMINE was an investigator-initiated, randomized, controlled, open-label trial.
Okay.
It was conducted across 2 mixed intensive care units in Brazil, which actually encompassed 8 individual ICUs within those 2 hospital sites.
That's a good spread.
Yeah. They focused on adult patients, 18 years or older, who definitively required orotracheal intubation. This is a very pragmatic, real-world setting, basically capturing a broad swath of critical illness, respiratory failure, sepsis, neurological emergencies.
Okay, I'm looking at the enrollment numbers here,
Mm-hmm.
and the flow of patients into this trial tells a story of its own.
It really does.
They identified 722 patients who had an indication for intubation.
Right.
However, 515 were excluded.
Yeah.
I have to stop you right there. A massive chunk of those exclusions, 323 patients to be exact, was simply due to the unavailability of the study team.
Yeah.
How can we trust a trial where they excluded over 300 patients just because the research team wasn't around? Doesn't that ruin the real-world applicability? Like, are we just studying the stable 10 a.m. intubations?
That is a phenomenal question, and it's honestly a very common critique of critical care literature in general. But we have to look at the reality of conducting emergent, time-sensitive research.
Which is incredibly hard.
Exactly.
Yeah.
Obtaining informed consent and properly randomizing a patient while they are actively crashing is incredibly difficult. If a patient decompensates at 3 a.m. and needs an airway immediately, and the research coordinator isn't standing right there, that patient cannot be enrolled safely or ethically.
Right. You can't just hit pause.
No, it is a pragmatic constraint.
Right.
So it doesn't invalidate the trial, but it does remind us that clinical trial populations are a specific, often slightly more stable subset of the patients we actually treat.
I suppose that makes sense. You can't delay a life-saving intubation to page a researcher.
Exactly.
So after all the exclusions, ultimately 207 patients were randomized and 175 ended up in the modified intention to treat analysis.
Right.
That gave them 91 patients in the ketamine group and 84 in the propofol group. What did they actually do with these patients?
So the patients were randomized 1-to-1 to either receive ketamine or propofol, but here's the crucial methodological choice they made.
Okay.
They used fixed weight-based dosing. Ketamine was uniformly dosed at 2 milligrams per kilogram of estimated body weight, and propofol was uniformly dosed at 1.5 milligrams per kilogram.
Wait, they mandated 1.5 milligrams per kilogram of propofol for critically ill ICU patients.
They did.
In actual nuanced bedside practice, I very rarely use fixed standard doses for shocked or severely ill patients.
Right, nobody does.
The art of critical care involves radically reducing the induction dose. If I have an elderly patient in septic shock, I am absolutely not giving them 1.5 milligrams per kilogram of propofol.
It would be terrifying.
That's a massive dose for a fragile patient. I might give them a fraction of that, carefully titrated. Testing fixed, unadjusted doses seems to fly in the face of clinical common sense, doesn't it?
It does diverge from the nuanced bedside art, for sure, but it's a methodological choice with a very specific purpose.
Which is?
Well, by enforcing a fixed dose, the researchers are rigorously testing the pure pharmacological effect of the drugs at their standard recommended induction levels. They are removing the confounding variable of clinician variability.
Oh, we'll see.
Imagine if they allowed everyone to titrate. The physicians, fearing propofol, might give tiny homeopathic doses of propofol while confidently giving massive doses of ketamine.
Because of the safety blanket effect.
Exactly. If they did that, it would be impossible to compare the true hemodynamic profiles of the drugs themselves.
Okay, I see the logic. It isolates the variable of the drug itself.
Right.
It tests the drugs in a standardized vacuum, which might amplify the adverse effects compared to how an experienced intensivist might gently coax a patient off to sleep. But it provides a clean, scientific look at what these agents do at these specific doses.
Exactly.
So they push these fixed doses. What were they measuring as their main marker of success?
The primary outcome chosen by the authors was the lowest mean arterial pressure, or MAP, recorded within the first 10 minutes after induction.
Why specifically the lowest MAP within 10 minutes? Why not look at cardiac arrest rates or survival to hospital discharge or something that actually matters to the patient's family right away? A blood pressure number on a screen seems like a weak primary endpoint.
I hear that. The rationale comes down to trial mechanics and capturing immediate physiological insult.
Okay.
You can think of the first 10 minutes after induction as a physiological hurricane.
I like that analogy.
The authors wanted to sensitively capture the immediate hemodynamic dip that usually precedes overt cardiovascular collapse. That 10-minute window is when the pure pharmacological effects of the induction agent are peaking. The physiological stress of the laryngoscope blade is occurring, and the transition to positive pressure ventilation is shifting intrathoracic dynamics.
So it's like testing a ship's hull.
Oh, exactly.
You don't test a ship's structural integrity when it's docked safely in the harbor hours later. You test it during the first 10 minutes of a hurricane.
Perfect analogy.
That 10-minute window is the hurricane, and the lowest MAP is the deepest structural strain on the hull.
That is a perfect way to visualize it. By measuring the absolute nadir of the MAP in this tight window, they capture the immediate physiological insult of the drug before the clinical team has time to fully compensate with heavy vasopressor titration.
All right, so how did our two drugs fare in the hurricane? Let's look at the numbers.
Okay, so the lowest MAP recorded within the first 10 minutes for the ketamine group was 66 millimeters of mercury. For the propofol group, the lowest MAP was 60 millimeters of mercury. When they ran the adjusted analysis, the mean difference between the two groups was exactly 6 millimeters of mercury.
6 millimeters.
Yes, and this achieved borderline statistical significance with a p-value of 0.050.
So mathematically speaking, ketamine won the primary outcome.
Technically, yes.
It resulted in a less pronounced drop in the mean arterial pressure.
Yeah.
But As a clinician, I have to look at the reality of a 6 millimeter difference.
You have to.
If I am standing at the bedside, looking at the arterial line tracing on the monitor, a MAP of 66 versus a MAP of 60, yes, one is technically higher, but in the chaotic dynamic environment of an intubation, a 6 millimeter difference is almost imperceptible.
Right.
It's the difference between the monitor reading 62 on one beat and 56 on the next, just because the patient took a shallow breath or someone bumped the bed.
Exactly.
It is a razor-thin margin. Why does 6 millimeters even matter?
Well, the authors themselves grapple with that exact question. They explicitly concluded that while there was a statistical difference, this 6 millimeter advantage was neither clinically meaningful nor was it sustained.
Not sustained.
Right.
Yeah.
We have to look beyond that immediate 10-minute dip. When the researchers calculated the average MAP difference over the entire first hour post-induction, that 6 millimeter gap shrank to a mere 1.67 millimeters of mercury.
Wow. So it basically vanished.
It vanished. And crucially, the confidence intervals for that 1 hour average crossed zero, meaning there was no statistically significant difference whatsoever over the first 60 minutes.
So mathematically, ketamine gives you a tiny 6 millimeter cushion for a few minutes, and then that advantage completely evaporates.
Basically.
The safety blanket is remarkably thin.
Very thin.
But honestly, a monitor reading doesn't tell us if a patient actually survived the procedure. We have to look past the numbers on the screen and look at the physical realities in the room. Did these patients actually crash?
That is the pivotal question, right? And it brings us to the secondary outcomes, which focus on actual clinical events. Let's look at the rates of cardiovascular collapse.
Okay, lay it on me.
In the trial, cardiovascular collapse occurred in 22% of the patients receiving ketamine.
22%.
In the Propofol group, the rate was 33%.
Wait, hold on. A 33% collapse rate?
Yeah.
If I see that in a trial, my immediate instinct is to ban Propofol from my ICU entirely. That sounds like a horror show. How are the authors, and how are you justifying that this isn't a massive red flag for Propofol?
I completely understand that reaction, but we absolutely must deconstruct how collapse was defined in this specific trial.
Okay, how do they define it?
It changes the entire narrative.
Yeah.
In PROMINE, the higher rate of cardiovascular collapse with Propofol was driven primarily by one specific criterion: a brief escalation of vasopressor dose within the first 2 minutes after induction.
Oh, I see. It almost sounds like driving a car. If you are driving and you know you are about to tap the brakes, which in this analogy is pushing Propofol, knowing it causes vasodilation, you instinctively press the gas pedal a little harder immediately afterward to compensate and maintain your speed.
That is precisely what the data suggests is happening at the bedside.
Okay.
The clinician pushes the Propofol. They anticipate the pressure dip because they know the pharmacology.
Sure.
They see the MAP start to soften, and they instinctively reach up and bump the norepi drip up a few cc's. That reflex action, that momentary intentional bump in the norepi within the first 120 seconds, triggered the definition of cardiovascular collapse in the study's parameters.
So the data is actually masking a behavioral quirk of the doctors, not necessarily a failure of the drug.
Exactly.
Is that a true catastrophic collapse, or is it just an expected transient physiological reflex that is being actively and successfully managed by routine critical care?
The surrounding data strongly points to the latter. If we look at the other early hemodynamic markers, the picture looks much more balanced.
What else did they look at?
Severe hypotension, as a distinct metric separate from the vasopressor bump, was incredibly common in both groups: 37.4% with ketamine and 46.4% with Propofol.
High for both.
Very high. And severe hypoxemia was nearly identical: 25.3% in the ketamine group versus 25.0% in the Propofol group.
Both drugs are causing severe physiological derangements at roughly similar rates. The Propofol group just required a faster hand on the vasopressor dial in the first 2 minutes.
That's the takeaway. And the long-term data bears out that this was a transient management issue, not a sustained circulatory failure.
Right.
By the 1 hour mark and out to the 24-hour mark, the total vasopressor needs measured in norepinephrine equivalents were similar between both groups.
Wow.
The Propofol group didn't require massive ongoing vasopressor support compared to the ketamine group. They just needed that initial brief bump to counteract the expected vasodilation.
That completely flips the script on how we view that 33% collapse rate.
Hasn't it?
It's a reflection of clinician behavior and expected pharmacology, not necessarily a failure of the drug to support life.
Exactly.
But, while those early hemodynamics seem similar once actively managed, There is a secondary signal in the trial that we cannot ignore. We need to talk about mortality.
We do, and we have to tread very carefully here.
Right.
At 7 days post-intubation, the mortality rate was numerically higher in the ketamine group.
Okay, what were the numbers?
It was 33.0% with ketamine compared to 23.8% with propofol.
That's a big gap.
It is. Furthermore, this trend continued downstream. Both ICU mortality and hospital mortality were also numerically higher in the patients who received ketamine.
I am struggling to square this. A nearly 10% absolute difference in mortality at 7 days for the drug that is universally assumed to be the safest option.
Right, the safest.
Even though I know we have to be careful with secondary outcomes, the psychological impact of seeing that number is profound.
Absolutely.
It shatters the illusion of zero risk. When we reach for ketamine, we tell ourselves we are making the safest choice. This data whispers that maybe we aren't. Are we sure about this mortality signal?
We must state a crucial caveat right now, as loudly and clearly as possible.
Please do.
The PROMINE trial was not powered to detect differences in mortality.
Got it.
The sample size of 175 patients is far too small to draw definitive conclusions about survival. These findings must be interpreted strictly as hypothesis generating. We absolutely cannot look at this trial and state as a fact that ketamine causes higher mortality than propofol.
I accept the statistical restraint. We cannot make causal claims based on an underpowered secondary outcome. But as clinicians, we have to ask, why might this happen?
We have to wonder.
If ketamine provides a slightly better MAP in the first 10 minutes, why might more of those patients die a week later? What are the unmeasured negative effects of ketamine that might be impacting the long-term ICU trajectory?
We have to look at the cascade of events that follows a ketamine induction.
Okay.
We know ketamine is a dissociative anesthetic. It can cause profound dysphoric emergence phenomena. Patients can wake up terrified, hallucinating, and fighting the ventilator.
And what does a dysphoric thrashing patient require?
Heavy sedation.
Exactly. They require massive amounts of deep sedation, often continuous propofol or midazolam infusions, just to keep them safe and synchronized with the ventilator so they don't pull out their breathing tube.
Right. The initial choice of ketamine might trigger a vicious cascade.
Okay, walk me through the cascade.
Dysphoria leads to agitation. Agitation leads to heavy, prolonged sedation.
Right.
Heavy sedation leads to prolonged mechanical ventilation, an increased risk of ventilator-associated pneumonia, profound ICU delirium, and severe ICU-acquired weakness.
Which are all terrible.
These are all factors that independently drive mortality long after the initial 10-minute intubation window has closed. We might be trading a marginally better blood pressure on day 1 for a much more complicated, protracted, and dangerous ICU course over the next 2 weeks.
To really understand why ketamine failed to be the hemodynamic silver bullet we all wanted it to be, and why it might have these complex downstream effects, we need to look under the hood.
Yes, let's talk physiology.
We need to explore the actual cellular biology and physiological state of a critically ill patient.
Let's break down the myth of ketamine's magic. Ketamine is unique among induction agents. Its perceived hemodynamic benefit relies heavily on sympathetic stimulation.
Okay.
Unlike propofol, which directly depresses the system, ketamine prompts the central nervous system to release endogenous catecholamines, your body's own natural adrenaline and noradrenaline.
Right.
It also inhibits the reuptake of these catecholamines at the synaptic cleft, keeping them in circulation longer. This massive sympathetic surge is what drives up the heart rate and the blood pressure.
It almost sounds like squeezing a sponge, right?
That's a great way to think about it.
If ketamine's job is to squeeze the adrenal glands for adrenaline, that works perfectly in a healthy trauma patient who just got rolled into the ER. They have a full sponge.
A very full sponge.
But if I'm a patient in day 3 of severe septic shock, my sponge is already bone dry. Am I picturing that mechanism correctly?
You are picturing it perfectly. That is the fatal flaw in relying on ketamine for our specific ICU population.
Wow.
Critically ill patients, especially those presenting in severe distributive or cardiogenic shock, are fundamentally different from a healthy patient. Their sympathetic nervous system has been running at maximum capacity for days.
Just totally burnt out.
Exactly. At a cellular level, their alpha and beta receptors are downregulated. The vesicles in their adrenal medulla are depleted. The tank is completely empty.
So you push the ketamine, it tries to squeeze the sponge, and nothing comes out.
Nothing comes out.
And when that sympathomimetic effect is blunted because the patient is catecholamine depleted, what are you left with?
You are left only with the direct myocardial depressant effects of the drug itself.
Wait, ketamine depresses the heart too.
Yes. At a cellular level, ketamine, just like propofol, has direct negative inotropic properties. It blocks calcium transients in the myocardial cells.
That is wild. I feel like we never talk about that.
We usually don't see this myocardial depression because it is entirely masked by the massive sympathetic surge. But in the exhausted ICU patient, the mask slips, the sympathetic surge fails to materialize, and the blood pressure crashes anyway.
That physiological reality perfectly explains the PROMINE result.
It really does.
It explains why the ketamine group still had a 37% rate of severe hypotension. Their endogenous catecholamine reserves were simply tapped out.
Yep.
Now let's look at propofol through that same physiological lens. We know propofol causes vasodilation.
We do.
It interacts with the smooth muscle lining the arterial walls, inhibiting the calcium channels that keep those vessels tight. The vessels relax, the container gets bigger, and because the volume of blood stays the same, the pressure plummets.
Correct.
But is there a hidden advantage to this?
The advantage is predictability.
Predictability is everything when you are managing a crisis.
Absolutely.
If I push 1.5 milligrams per kilogram of propofol, I know exactly what the physiology is going to do. The systemic vascular resistance is going to drop.
You can bank on it.
Because I know this with absolute certainty, I can preemptively manage it. I'm not standing there hoping the patient's internal adrenal sponge has a few drops of adrenaline left. I am taking control of the physiology myself.
And that leads us directly into a vital part of this analysis. The practical steps for managing hemodynamics during airway procedures in the ICU, regardless of whether you choose propofol, ketamine, or any other agent.
Because we have to manage the drug.
Right. The PROMINE trial highlights that no drug is a magic bullet, so the management surrounding the drug is what ultimately saves the patient's life.
Let's talk about vasopressor readiness because this feels non-negotiable.
It should be non-negotiable.
Before you push any induction agent in a critically ill patient, you must have a vasopressor ready. Ideally, this means having a peripheral or central norepi drip pre-mixed, fully primed through the tubing, connected to the patient, and running on a pump.
Yes.
You don't want it sitting in a bag on the counter.
No, you do not.
You want to be able to reach out and dial it up the literal second the induction agent is pushed. In my unit, we often start a low-dose norepi drip before we even push the sedatives, establishing a baseline of support that we can titrate up as the drugs take effect.
That's best practice. Vasopressor readiness is step 1. Step 2 is fluid resuscitation and volume assessment.
Okay, tell me about that.
You have to evaluate the patient's volume status before the procedure begins. If they are profoundly hypovolemic, the vasodilation from propofol or the sudden loss of sympathetic tone from any anesthetic will be catastrophic.
That's what I was tank.
Exactly. A judicious fluid bolus, if clinically appropriate based on their cardiac function, can provide the necessary preload to buffer the hemodynamic hit.
And all of this needs to be embedded within a structured workflow.
Absolutely.
Intubation cannot be an ad hoc, chaotic event where everyone is yelling. It requires checklists. It requires defining roles clearly. Who is managing the airway? Who is pushing the drugs? Who is staring exclusively at the monitor with their hand on the norepi dial?
Dedicated roles are so important.
Because we have to prepare for the immediate hemodynamic crash that occurs not just from the drugs, but from the mechanical ventilator itself.
The ventilator's impact is a crucial physiological concept that often gets completely misattributed to the induction drugs.
Right.
Let's break down the physics of it. Normally, when you take a breath, your diaphragm drops, creating negative pressure in your chest. That vacuum physically sucks air into your lungs, but it also sucks venous blood back into your heart from the vena cava.
But when we intubate a patient and put them on a ventilator, we completely reverse that physics. We transition them to positive pressure ventilation.
Right. The ventilator forces air into the lungs under pressure.
And what does that do?
That increased intrathoracic pressure acts almost like a pneumatic tourniquet inside the chest.
Wow, pneumatic tourniquet.
It physically compresses the vena cava and forcefully opposes venous return to the right atrium.
So less blood gets to the heart.
Exactly. The preload drops precipitously, and according to the Starling curve, when preload drops, cardiac output plummets and the blood pressure crashes. This mechanical insult happens regardless of whether you use ketamine or propofol.
The drug might start the pressure drop by relaxing the blood vessels, but the ventilator finishes the job by cutting off the blood return to the heart.
Exactly.
A structured workflow anticipates this cumulative two-part physiological assault. You optimize the hemodynamics, start the norepi, and fill the tank before the laryngoscope ever enters the mouth.
The underlying physiology makes perfect sense of the PROMINE results. It explains why ketamine's advantage is so fleeting and why Propofol's drop is manageable.
Right.
But to fully trust these conclusions, we have to rigorously evaluate the evidence itself. What are the strengths and limitations of the way this trial was built?
Let's start with the strengths. What did the authors of the PROMINE trial do well that makes us trust this data?
The strengths of this article are actually quite significant. First and foremost, it is a randomized controlled trial addressing a profoundly practical, everyday ICU question.
Which is rare and awesome.
It is a massive contribution, as we've relied on observational data for too long. They utilized concealed allocation, meaning the clinicians couldn't game the system to get their preferred drug for a specific patient.
Right, no picking and choosing.
Furthermore, while the clinical team at the bedside was unblinded, the outcome assessors and the statisticians were blinded, which significantly reduces analytical bias.
That's a solid design.
And finally, their data collection was superb. They collected highly granular and frequent early hemodynamic measurements.
Right, the MAP every 2 minutes.
Yes. Recording the MAP every 2 minutes allowed us to see that rapid transient dynamic of the vasopressor bump, rather than just giving us a blurry snapshot of the whole hour.
Those are robust elements. But I have to bring up the limitations because no trial is perfect.
Of course.
First, as you mentioned, it was an open-label design. The clinicians knew exactly what drug they were pushing.
Right.
Going back to our discussion about the cardiovascular collapse definition, knowing you pushed Propofol might subconsciously influence how quickly you reach for the dial. You expect the drop, so you treat it faster, which paradoxically drives up the collapse rate in the data.
It's true. Performance bias is largely unavoidable in open-label trials with visual differences in the drugs.
Because they look totally different.
Yeah, Propofol is a milky white lipid emulsion, and ketamine is a clear liquid. You simply cannot blind the person pushing the syringe.
Second limitation, we have to acknowledge the modest sample size. 175 patients analyzed is enough to detect a mathematically tiny 6 millimeter difference in MAP. But as we noted, it is vastly underpowered to detect true differences in patient-centered outcomes, like mortality or long-term neurological recovery.
Which is why we're just generating hypotheses there.
Third, we have to remember those high exclusion rates due to simple logistics, the study team availability.
Right.
This means we are looking at a convenient sample of intubations, most likely occurring during daytime hours or when research staff was present, which might not perfectly reflect the utter chaos of a weekend or middle-of-the-night crash intubation.
That's a very fair point. Another significant limitation is the fixed drug dosing we discussed earlier.
Oh, yeah.
Testing fixed doses of 2 milligrams per kilogram for ketamine and 1.5 for propofol, rather than allowing tailored symptom-directed titration, limits the external validity.
It does.
It doesn't mirror the nuanced, individualized practice of an expert bedside clinician modifying doses for an 80-year-old in septic shock.
And the foundational limitation of the trial, I think, is its reliance on a surrogate physiologic primary endpoint.
Yes, the MAP.
An MAP within 10 minutes is a number on a screen. It is not a patient-centered outcome. We're inferring that a slightly lower MAP is inherently bad, but the trial itself showed that this tiny difference didn't translate into any sustained benefit for the patient.
Exactly.
We always have to be wary of trials that claim victory based on surrogate markers when the actual patient trajectories don't diverge significantly in a positive way.
Right. So bringing all these threads, the physiology, the methodology, and the clinical reality together, the ultimate question is, how should you, the listener, actually change your practice tomorrow morning when you walk into the ICU?
That is the bedside bottom line. If you are standing there with the syringe staring at the monitor, what do you do differently based on this article?
The core lesson from PROMINE is about dismantling dogma.
Okay.
This trial does not prove that propofol is universally safe for every shocked patient. It doesn't give you a free pass to push large doses of propofol in the setting of profound hypotension.
Obviously not.
Conversely, it absolutely does not prove that ketamine is inherently dangerous or should be banned from the ICU.
Right.
Instead, it challenges reflective, dogmatic decision-making. It tells us that reaching for ketamine simply because it's better for the blood pressure is a vast oversimplification of complex cellular physiology, and that perceived hemodynamic advantage is incredibly fragile and fleeting.
The ultimate takeaway is the absolute necessity of the whole patient approach. Your choice of sedative should never be based on a drug's historical reputation alone.
Never.
It requires analyzing the entire clinical picture in front of you, You must consider the baseline MAP.
Right.
You must assess the patient's specific shock state and their likely endogenous catecholamine reserve. Are they early in their disease process with a full adrenal sponge, or are they days into severe sepsis with a bone-dry reserve?
Sure.
You must factor in your own vasopressor readiness, your fluid resuscitation status, your oxygenation strategy, the patient's aspiration risk, the absolute need for neuromuscular blockade, the operator's skill level, and, crucially, you must anticipate the inevitable, profound physiological shifts that will occur the moment the ventilator starts pushing positive pressure into their chest.
It is about moving away from asking the simple question, which drug is better, and moving toward asking which drug is best for this specific patient at this exact moment, managed by this specific clinical team.
Beautifully said.
PROMINE provides the granular data to empower that nuanced thinking. It gives us permission to critically evaluate our long-held assumptions and build a safer, more individualized, mechanistically sound approach to securing the airway.
Final bottom line, in critically ill adults undergoing rapid sequence intubation, ketamine produced a modest and transient early MAP advantage compared with propofol, but no sustained hemodynamic benefit and no proven improvement in patient-centered outcomes. PROMINE reminds us to choose induction agents based on the whole patient and the whole airway process, not on drug reputation alone.
Thank you for spending your time with PRISM Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.